Hello, everyone joining us in the virtual room. We're going to get started in just a moment. We'll give folks a chance to come on in. Very glad to see you today. Feel free to introduce yourself in the chat if you would like. Like I mentioned, we'll get started in just a moment. Oh, yes. Thank you, Bonnie. Let's see if anyone on our team can potentially turn on closed captioning. There should be an automatic feature in Zoom to do that. All right, we're going to go ahead and get started as folks are still joining us. So again, hello and welcome to this second session of our webinar series on caring for an aging population. My name is Ariel Mather, and I am the program manager of the National Center for Equitable Care for Elders. If you missed our first session of this series, it was last week, we did try to make any links to the recording and the slides available in our reminder emails, but what we will do is follow up after this session with all slides and links to recordings. This recording will be made available as soon as it's closed captioned. So we're going to go through the introductory content and housekeeping very quickly. If you're not familiar with our center, we hope that you will continue to connect with us going forward. We provide training and technical assistance to community health centers and community-based organizations across the country who provide care for older adults. Just plugging the Health Center Resource Clearinghouse, like we always do, lots of great up-to-date information, not only on COVID-19, but things like monkeypox, a lot of other topics very relevant to caring for your health center population. We're very familiar with Zoom reminders by now, but all lines are muted to prevent background noise, but we would love to hear from you today, both in the chat, the Q&A feature, in response to anything our facilitator or panelists mentioned today. We'd love to hear from you. We'd also love to hear your feedback. So a quick evaluation is going to pop up at the end of this session. We hope you'll take a moment to fill that out and let us know what you think. So you should be familiar with the learning objectives by now, but today we're really focused on identifying and integrating some age-friendly strategies into our health centers and other lookalike locations. So we're first going to start with a quick review of last week's content, as well as some content in response to some of the questions we got in session 1. And at this point, I'll turn it over to our facilitator, Dr. Peter Miramaldi, who's our SDOH subject matter expert for our center. So Peter, take it away.
Thank you very much, Ariel. I'm very happy to be here, and welcome back to those of you who were here last week, and welcome to you, those of you who are just joining. I would direct you to the slides available on the website if you're interested in any of the material that was previously presented. Next slide, please, Ariel. So just by way of a really quick review, let me just say this, they're coming. And most of you know this already, and I'm sure I don't have to convince you, but we've been watching this for the past 30 years, this groundswell of people over 65. And on September 1st, 2011, baby boomers started turning 65, which put enormous strain on the federal budget with Medicare and also on healthcare. But if you look on this, these charts, you can see the distribution. While there's not as many people at the end of the age spans here, this is where people require the most care, as you well know. The other thing I'd like to just mention is that the fastest growing segment of the population proportionally is 65 and older. Next slide, please, Ariel. In case you're wondering, this is a very recent poll out of Michigan. 82%, according to this representative sample of people between the ages of 50 and 80, 82% of people in this age group experienced ageism. You can look at the rest of the numbers here. I'm not going to dwell on it, but if you have any doubt about it, ageism is present and rampant. Next slide, please, Ariel. When we talked about ageism last time, quite a few questions came up about intersectionality. And it's this is just a culmination of what I've experienced in public health and social work and what I read in the literature and scientific and gray literature. But it's just a pretty, I guess, just a comprehensive overview. You can read this yourself, but the idea is that intersectionality merges many identity markers, and it's very complicated, but it involves power and oppression. Next slide, please, Ariel. I scoured the literature in preparation, and I know everybody's busy, but I would highly recommend, if you were going to read one article, or if you wanted to bring an article back to your center, or if you're going to do a training, this is a terrific article. It happens to be on intersectionality with older folks living in rural areas, but the literature review is excellent and up to date. So I would direct you to it. And what you'll see is that there's, when Crenshaw started and introduced us to this concept of intersectionality in 1989, how it's evolved over the years. Next slide, please, Ariel. This is a deeper dive for those of you who want to hit some more literature. It's a special issue of the American Journal of Public Health. These are all linked as well. And this talks about where we were, where we are, and where we're going in terms of our understanding and application of this theoretical concept of intersectionality. I highly recommend it. And you can see on this slide, it moves into praxis. So we can come back to this if we want, but I want to keep moving, please, Ariel, and just talk about it more visually. I think the important thing, and I think the questions that were raised last week reflect your deep understanding of how this is about power and exclusion and oppression of certain groups. And it's very complicated. I looked around and I grabbed this from the University of British Columbia. These are linked, but you can see here, this is a program where they start asking people to locate themselves on this wheel of power. And where do you sit on this? And if you just look at something like housing, for example, we go from homeless to property owner. And housing, if we think about social determinants of health, is one of those core foundational issues that we sometimes, I hope we think about it in healthcare, but do we really think about it? Do we really walk the walk and think about where people are living? I think many people do, many healthcare providers do, but you can see, look around this slide and where would you locate yourself on this? And the idea is that power is concentrated the closer you get to the center of this circle. And you're more likely to be excluded or oppressed if you land somewhere outside on the outer rings. Next slide, please, Ariel. Excuse my clip art here, but this is me. I just think of it this way. So I think about hegemony, power, and oppression, and there's these constant forces. And this dotted line is what we like to think of as all-inclusive healthcare. I don't think I've ever met anywhere. I travel around the country a lot and I visit healthcare facilities and interview providers, caregivers, patients. I have never heard anybody say they're not inclusive. But if you think about it, these are some of those intersectionality identities. Erase some of these and put others in that I'm not putting here. It may be specific to your center. It may be specific to your population, but there's this constant force that's pushing people against this perimeter. Next slide, Ariel, please. And there's just one now, but every once in a while, something happens. In this case, it would be ageism that pushes older populations outside of that all-inclusive healthcare. And typically, it wouldn't just be age, it would be combined with something else, like SES or disability or ethnicity or race, but there would be multiple identities that result in getting pushed out of this all-inclusive. And the thing to remember is very often well-intentioned people don't realize that they're doing this. Next slide, please, Ariel. So how do you dismantle these effects when you're trying to make an age-friendly system? Next slide, please, Ariel. I'm going to make two quick suggestions. So, we could do a whole session on this, but one of the things to think about are these kinds of, awareness, public health messages, advocacy. We showed you this slide part of this slide last time, but just make people aware of the population. This is something we do. I suggested to you last time that we take a harm reduction approach and borrow from the harm reduction literature, which is a trend now. We're trying to, how can you eliminate the threats to ageism? And one of the things you can do is educate people. And there are so many different ways you can do this. And you can tailor these kinds of messages to your individual setting where you are with your population. This introduces issues of culture as well, where you can tailor that. The federal government now has a lot of resources online in multiple languages. It doesn't mean that they're going to match culturally, but at least we're getting closer to what we talked about last time with that cultural and linguistic relevance. Next slide, please, Ariel. A more direct way to do this, and this would be more for staff, and if you haven't done these kinds of these measures before, this is the implicit association test. It's a project here at Harvard. And if you look closely, you can see that this isn't, I'm going to say it's not psychometrically validated, but it's a very useful tool. I've used it a lot in trainings. We used it with medical students at Harvard here and dental students at Harvard in the past. It's really interesting, but there's, just to give you an idea, religion, skin tone, transgender, age is in there, race, sexuality, Arab, Muslim, weight, gender science, things that people are prejudiced about. There's a new one about presidents of the United States. So it's very interesting to heighten our awareness. And what this does, it eliminates blind spots. It helps people be aware of the fact. And when I do these, I like to ask people to do them privately, so there's no embarrassment. Next slide, please, Ariel. Again, Don Barrick's quote here, when integration is lacking, patients are lost and activities don't take place. This is exactly where errors occur, and this is where we get more complicated issues. And it's easy to talk about, do you have the structure? Do you have the process? But do you really have the process? I met with a family yesterday. It took them 22 minutes to describe to me what happened to their elder before we got into anything else. Do you have the process? Do you have the 22 minutes it takes to meet with that patient? 2 days ago, I met with a psychiatrist and was complaining about they're getting in their service 12 minutes a patient. There's more pressures on this. It's just almost impossible, all these competing demands. But this is what we're up against. Next slide, please, Ariel. You're all expert in integrated care. I'm sure you could write the book on integrated care. But when we're talking about older adults, it changes the landscape a little bit. And a lot of it has to do with, I just mentioned, how much time it takes. Because not only are you speaking with the patient, but then you have to deal with the patient's caregivers very often. And it can become very complicated. I have countless examples of people who had very, very negative experiences in integrated care. But I think those are experiences that easily fixed. I was talking to someone who took Asian woman took their elderly grandmother for a surgical procedure. And a surgeon came in and said something quickly, drew with a marker on the skin and left. And the grandmother was horrified. There was this kind of like, in thinking about it, he's like, oh, the surgeon's terrible. We have no idea what kind of pressures that surgeon's under either. Is it appropriate? No. But could that surgeon learn? How do we communicate these sorts of things? These 4 boxes here, and what we're going to talk about today with our expert panel, are the importance of integrating these kinds of approaches. And if you think about it, thinking past the clinical setting, how important it is to know where people live in the community, to think about the ecology, to think about Bronfenbrenner's systems theories, this ecological perspective, where people live, everything affects them. Next slide, please, Ariel. And if you go into session 1, if you go back to the slides, there's terrific locators to find resources in your area. There's 3 different locators to find different types of resources. What we're going to talk about today, we're going to take a deep dive into the 4 M's, but this age-friendly health systems is an initiative you can see here from Hartford Foundation, IHI, American Hospital Association, and Catholic Health Association of the United States. And next slide, please, Ariel. And what we're going to do today is talk about these 4 M's. The thing to remember is that you can't do one without all of them. It's so very important. And in each case, one may rise to the top. My experience has been the hardest part often is to understand what matters and to be able to translate what matters to the patient to the rest of the team. especially when there's great expertise abounding here. So, and I'm looking forward to hearing from the panel about this, but this idea that, these are the 4 ways to sort through this extremely complex ecology that people bring. Remember the example last week was you drop a single pebble into a still pond, a still body of water, and the rings go out. Then you take a handful and throw them in, and these concentric rings all interact. That's what the patients come from when they walk through the door. How can you figure that out? This is a good way to figure it out. Next slide, please, Ariel. And if you're doing trainings, I redirect you to this as the evidence for this slide. For the 4M's approach, it's evidence-based. Next slide, please, Ariel. If you go into the IHI webpage, there's a lot of resources such as this. And I look forward to hearing about the first bullet here, how you ask the older adult what matters most. And with that, next slide, please, Ariel. It is my pleasure to introduce to you our expert panel, Drs. Porter and Wallace, representing the Cherokee Health System, and Dr. Peterson, representing Shawnee Health. So thank you. Oh, Lori, you're on mute. I do it all the time.
Thank you. So good to be with you. Thank you for the introduction. I'm Laura Porter with Cherokee Health Systems. And as a foundation for describing our organization's pathway to enhanced age-friendly care, we'd just like to share some general information about Cherokee Health Systems. Since its establishment in 1960, Cherokee Health Systems has provided care to medically vulnerable and underserved populations, including older adults. We are a federally qualified health center and licensed community mental health organization with 21 traditional clinics in Upper East Tennessee, as well as Chattanooga and Memphis. As a safety net provider, Cherokee is committed to ensuring that all members of our communities can access effective, high-quality care, regardless of insurance status or ability to pay. In 2021, Cherokee Health Systems served almost 70,500 patients, including almost 18,000 new patients, for a total of approximately 458,000 healthcare services, and 14% of our patients were covered by Medicare. This slide is an image of our corporate office near downtown Knoxville.
Hey, well, back up, the previous slide was our corporate office. There we go. Okay.
Yeah. Next slide, please. However, many of our clinics more closely resemble this clinic in rural Washburn, Tennessee, where the population is approximately 3,200 people. So while we do have clinics in major urban areas like Knoxville, Chattanooga, and Memphis, our services are particularly valuable in more remote locations like Washburn, as you see here, or Blaine, New Tazewell, and Clarefield, Tennessee. Next slide, please. This image captures our organization's overall service area, and across the counties highlighted here, Cherokee offers a wide range of clinical services, including pediatric and adult primary care, specialized cardiology and dermatology, and a reproductive health clinic, behavioral health services, including child, adolescent, adult, family, and group assessment and intervention, outpatient psychiatric services, alcohol and drug services, medication-assisted treatment, intensive case management, evaluation and treatment of developmental disorders, school psychology services, and crisis intervention, as well as dental and pharmacy services. We'll turn now to our specific experiences expanding age-friendly care.
Thank you. I think our journey has been a good one so far, but as you can tell, Cherokee does a lot of things. So how do you get started in the focus for the older adult, which is right now 14% of our population? Having the structure of the 4M's with its evidence-based process really gave us a structure that we could present to our executive leadership. You can't go anywhere if you don't have buy-in from the people at the top. They also see these numbers that the older adult population is growing, and there's going to be more and more need for us to provide competent, quality, integrated services to this population. So fortunately, it's been a easy sell for us. Our teams, our CEO, our board is extremely supportive of this. But within that leadership, you have to have a team of champions to make this work, to help design the process. And in our case, our team was me. I'm now emeritus medical director, but I was medical director when we got started on this. Laura Porter, who is a clinical psychologist, and she's the director of our continuing education and also a grant writer. Our director of nursing was on this team because, again, this is not just providers, it is all the staff that are involved in the care of patients have to be in on these processes. We also had the fortune of having our clinical pharmacist as part of the team, and our IT champions. We couldn't live without them. We couldn't do what we're doing without the help in the medical record and help with data tracking, because we want to see if what we're doing is effective, and if not, what do we need to change? The grant funding from the geriatric workforce enhancement programs provided us so much support because we were able to block provider time for training. Let's face it, again, our providers are taking care of the entire age from birth to the end of life. So we do need to train. We need to help the providers and the nurses and the front desk and everyone to understand what we're trying to accomplish there. So the webinars and the training were very, very important. It allowed our clinical pharmacist time to provide handouts specific to reducing the number of medications, and she was able to take time to pull the data on the providers that were prescribing more medications and give them counsel and help in trying to reduce the number of medications. We were able to train providers in MOCA and other areas to evaluate cognitive function. We're able to bring in matter of balance into our offerings so that we can address the mobility area. Through funding, we were able to also have handouts when we do our Medicare wellness. We have a whole packet, and it's designed, it's coded with the 4 M's. There's information on each M, including what matters, so that we can try to increase awareness of how important it is for advanced directives and having these important discussions. We continue to enhance this care by our collaborations. And one thing that being part of this process has done is to help encourage us to make those outreach efforts within the community. I mean, we're busy, but it's important to connect with our area agencies on aging, Alzheimer's Association and Alzheimer's Tennessee. We can't move forward in true quality care if we don't have those collaborations with our community. Next slide, please. So, we do provide primary care and behavioral health services. They are guided by the 4 M's construct. And what we do is we use the annual wellness visit as sort of the place to really start to center this process. We are very intentional in this, and we are now working to engage people to make sure they understand the purpose of these visits, what we hope to accomplish, and we're having much better show rates in this because, again, the older adult knows that this is a time where their provider will listen to them and really talk about what's meaningful to them. The medication therapy management, our clinical pharmacist has been able to start this program, which excites, again, our C-suite because this is a This does generate funds for the organization, as well as providing important service to patients and reviewing their medications, making sure that they understand their medications, have an accurate medication list. I mentioned the Matter of Balance classes. We've had several of those now. And again, it's part of our process of taking care of the whole adult. And I will let Laura talk about Dementia Friends.
Sure. As the state sub-licensee for this program, Dementia Friends, we are committed to promoting awareness and understanding about dementia throughout Tennessee. Certainly anyone can become a dementia friend by watching a series of online videos and taking action to show understanding and support. And it has been a true pleasure to network and really develop relationships across the state with like-minded organizations and individuals to expand and promote ways to provide this important information to communities throughout Tennessee. So we encourage everyone to visit dementiafriendsusa.org and click Become a Friend. I would also like to highlight the ways that we're expanding our 4M's care into behavioral health. Dr. Wallace mentioned in primary care. And while that's certainly where we started, it's really exciting to be part of the launch into behavioral health as well. We began this arm of our initiatives approximately a year ago in discussions about what assessing and acting on the 4M's in behavioral health would look like, what assessments would be essential, which ones would be more peripheral, what would the most appropriate frequency be. And those early conceptual discussions led to kind of a pilot of one, talking about the 4M's with my older adult patients and expanding to 2 of my colleagues joining me. Then earlier this year, one of our partners with the Rush University, GWEP, presented a continuing education program around age-friendly care, and that launched a further expansion of behavioral health and 4M's. So we now have a cohort of 10 who are assessing and acting on the 4M's with our older adult patients. With grant funding, we've been able to preserve time for this cohort, like in primary care, to complete some online educational models, complete MOCA training, and just last week we had a follow-up conversation to talk through our experiences, discuss best practices and documentation, and address questions. So with that brief overview of Cherokee Health Systems and all our services, we'll be happy to hear from Shawnee and answer questions thereafter.
Right. Thank you. Really glad to be participating today. Becoming an age-friendly health system was one of the major goals on our last strategic plan. And so I'm just really happy to share these experiences with anyone who might be able to learn from them. Next slide. So I'm speaking to you from the far southern end of Illinois. Shawnee Health has both a medical service division with clinics in 4 towns in Jackson and Williamson County, and a social service division that provides a really wide variety of older adult services throughout the southernmost 18 counties in Illinois. And even though both of these divisions have always been very successful in their own rights, in the past, they pretty much operated in parallel without any connection to each other. And in the process of becoming age-friendly, we started coordinating with each other in ways that we never did in the past. Every element of our age-friendly program was planned together, and that has just been so beneficial for us. Next slide. So here's a quick look at who we serve in our 4 family practice clinics. So even though these clinics are in 4 neighboring towns that are all just lined up along Route 13 in a couple of counties, each clinic really has its own unique characteristics. And our Carterville clinic has the highest percentage of older adult patients. Last year, over a quarter of the encounters there were with patients age 65 or over. And so the clinic staff there were really interested in learning how to serve these patients better. And so they cheerfully agreed to be our guinea pigs
for testing out a lot of the new processes as we explored the 4Ms model. Next slide. So in phase 1, we were just working with Carterville, and I should mention that phase 1 was part of Rush University's Geriatric Workforce Enhancement Program. And we were just one little component of that much larger project, and Cherokee was right there with us. So you may see some similarities in some of the strategies that we have worked out, and that's because we have been learning from each other all the way through this process. So what happened in phase 1? Well, first of all, the staff learned a lot about age-friendly care. And I wrote providers here, but it wasn't just the providers. Everyone, down to the receptionists, learned about ageism, learned about effective communication strategies. This really is, awareness for the entire team. We worked out a basic framework for better communication back and forth between the medical team and the older adult services team when there was a referral, as long as the patient consented to that communication. Third, during this time, Carterville improved their preventive screening rates, especially for colorectal cancer screening. And the providers at our other clinics actually invited one of the Carterville doctors to come and do a presentation about this success. And he told them all about the importance of what matters. He said to them, have a conversation about what happy, fulfilling aging would look like for that individual patient. And then ask them, how does cancer prevention fit in with that? So that was really powerful testimony from him. Last but not least, they tested a lot of stuff for us, and they found some things that didn't work well. So for example, we found that having providers do their own Medicare annual wellness visits, it messed with the rhythm of patient flow through the clinic, and people were unhappy with that. So we switched to a nurse-driven model for those visits. We've got a Medicare wellness nurse, that's all she does. And she's able to spend 45 minutes to an hour having some really in-depth conversations with patients. And then she loops the providers in at the end. So some components of our age-friendly care, like depression screening and fall risk screening, take place in all kinds of visits with all kinds of providers. There's some other components that right now are mostly taking place in those annual wellness visits, like cognitive impairment screening. Next slide. So in phase 2, we expanded the model to our other clinics just as the pandemic hit. So that was super interesting. And here are some of the things that we learned in that expansion. So what matters? This is really the heart of the 4Ms, but it turned out to be the most challenging to document. The providers got it, but we practice team-based care. And so those patient priorities and goals need to be documented and obvious and accessible to every team member in every interaction if they're really going to have an impact on care. And until recently, we didn't have a good solution in our EHR for how to do that. And it was extremely frustrating to us to have the technology be standing in the way of the care that we wanted to provide. On the medication M, one strategy that seemed to make a difference for us was giving providers individual reports listing patient by patient all of the high-risk prescriptions that they wrote in a year. And we had our 2 in-house pharmacists introduce these reports to the providers and offer consultations on alternatives or dosage adjustments or any questions that they had related to high-risk medications. For mobility, when we started phase 1 at Carterville, one of the providers there had a background in physical therapy. So we had a provider champion for this M. when she left and the care manager at that site left, we kind of missed that enthusiasm. So we're doing a pretty good job of screening for mobility issues and raising that to awareness on a routine basis. But when it comes to crafting individualized mobility plans that really fit with the patient's own priorities, that's an area where I think we have a lot of room to grow. And last, mentation. This is one of the topics where the medical and social service coordination has been really helpful. So we track all patients with a dementia diagnosis, and we make sure that each of them gets referred to older adult services. And on their end, even if the patient and their family aren't interested in having somebody come to their home and do the traditional comprehensive assessment for services, they are still getting a monthly information packet in the mail for several months that gives them up-to-date information on all the services and resources in the community that might be helpful for them. So we break it up into several smaller packets, both so that they don't just get like overwhelmed with all the information at once, but also to sort of keep that relationship active and alive for a while. Next slide. And meanwhile, this is just a little sampling of what our older adult services team was doing out in the community while phase 1 and 2 were happening in the clinics. We've created our own educational 4M booklet for older adults where they can record their medication information, fill out a fall risk screening, write down all of their questions and concerns related to 4M topics, and then they can bring that to medical appointments, even if their provider is not an age-friendly provider and doesn't know about the 4Ms. The patient can start that conversation. We've got staff who are installing grab bars and other safety features in people's homes. They are teaching matter of balance classes out in the community. They are always on top of the latest local resources for dementia support. So that's where we are now. In some ways, I think we are just scratching the surface of what the 4M model can bring to care. And we are definitely going to continue to deepen this transformation over time.
Thank you very much, Dr. Peterson. I just love hearing about all this stuff. So we have a couple of canned questions, and I saw some questions come up in the chat, but to get us started, I would like to start by asking Drs. Porter and Wallace, what did it take to get buy-in? And I know, Dr. Wallace, you alluded to this in your comments, but what did it take to get buy-in to implement a 4M's age-friendly framework?
First of all, I think all of us have personal experiences with older adults, often in your family, your grandparents, your parents, or someone that you have had to go through the healthcare system with, and you see the gaps, you see what was missing, and everyone has stories, and they impact you and make you want to be part of a process to improve the care that we provide for older adults. It was just almost, yes, we're on board. But what we did was we were very intentional about the local teams at each clinic, at engaging them, having discussions with them, getting ideas about workflow. Because when it comes down to implementing this, it is, how do you make this work in a busy primary care practice where you're seeing babies? And, what do you need to do? So each clinic team, and they made little adjustments depending on their clinic about how best to bring this in to how they provide care to the older adult. And it was very important, particularly because we had to get in and work on the EMR so that we have things easier to enter data and have it. So again, what we obtain at any point of that we touch the patient, that, you know, the behavioralist, the social worker, the front desk, all of us can see where we are and what particular needs for that patient. So that, again, engaging the people actually providing the care within your clinic to be part of designing how you implement this. The education's important, but the implementation of what you learn really takes, you want their input and let them help to construct the process.
So like all good communication, it was two-way, but you went and listened to them, and as a result, they were able to tailor what you were presenting to their clinics, correct?
Yes.
That's awesome. Dr. Porter, anything else you want to add to that?
I think she captured it well. Personal experiences, objective data, kind of big picture drove the yes, and then being able to tailor that individually in those discussions with the actual providers at our clinics.
That's great. Dr. Peterson, how about you? How did you get buy-in?
Well, like I mentioned, we started with a clinic that had a particular interest in care for older adults. And so they did some of the heavy lifting. You know, they got the clunky first iterations. And we're so grateful that they were willing to do some of that hard work to make things easier for the other clinics where maybe it wasn't as obvious a fit, you know, right up front. When we went wide with it, I think it really helped that it was enshrined in our strategic plan for that 3-year period. You know, we do a pretty robust planning process with a pretty robust needs assessment, and it was clear, as you presented earlier, this is an area of care that's just going to become more and more necessary. And it's an area that it was clear that we were pretty far from the cutting edge. And so this is something that we committed to on every level of the organization, from the board of directors on down. And we committed to it, and we monitored it monthly for 3 years. So we've just concluded that strategic plan, and we're setting up the next one. So it'll be interesting to see if we can just keep that momentum going, even if maybe it's not one of our priorities for the next round.
Did you have any trouble with the EHR? Dr. Wallace mentioned that being a key point.
Yes.
Terrible.
Yes.
Yeah, it's a barrier, isn't it, Erica?
Mm-hmm.
And how about when you go outside, if somebody goes to an ED outside of your system, how are the teams dealing with that?
So we are lucky in that a large percentage of our ED visits and hospitalizations are with one hospital group, and we work well with them, and we have a pretty robust information exchange system with them. There's a smaller hospital that's in a different system, and we're still sort of catching up there. But yeah, that is huge, and there's still room to grow there in terms of how coordinated we are.
We're getting there, but wow, yeah. Anything else? Should we go to the next question, please? So you both talked about community partners, and this is something that's near and dear to me. And I think that I'd like to hear more about this, but what role do you play in supporting, and how do you expand these relationships? Or if you want to start with, how did you establish them?
I'm going to let, for us, Laura has been our real champion in this area. So Laura, you talk about what you have done.
Sure. I think we've been surprised and delighted by the significance and value as we continue to develop our network. So our focus around developing partnerships really began in earnest as we pursued becoming the sublicensee for the Dementia Friends program, since that does require statewide reach. And so I embarked upon what really became a year-long journey to make those connections and friendships, and they just continue to grow and build upon one another. For example, our connection with the Rush GWEP led to a connection with the Tennessee GWEP and additional training support. Our connections with the Alzheimer's Association that started just with a cold call or a cold email led to an invitation to present to a state advisory committee, to present at a town hall, to participate in regular consultation about infrastructure building, and just last week, an opportunity to collaborate with the University of Tennessee at Chattanooga and a new Engaging Communities team on the development of age-friendly congregations in faith-based communities. So it really becomes an exponential growing and combining of forces and passion and interest and resources around this topic. We are certainly increasingly excited and ready to launch into connections about supporting caregivers, whereas at this point we've been more focused around care and connections for direct patient services, but looking forward to enhancing that area as well. And again, just 2 weeks ago, a new partnership with our friends at UT here in Knoxville around the use of robots to support caregivers.
So that's very interesting. This cold call, do you have a lot of experience with cold calls, Dr. Porter?
I don't.
She's good
Not
at
prior
it.
to
though.
this
She's good at it.
Reach out to a friend.
So, I think that we posted these locators. I mean, that's a really good place for people to start, people who are listening in. And cold calls can be done. And, I think that people are typically more receptive than we anticipate. And, sometimes it doesn't work out, but it's so worth it. It's wonderful to hear that you're having all these opportunities. What about you, Dr. Peterson?
So I feel like it was a huge advantage for us that we basically had our own in-house community partner, medical and older adult services together in one organization. But as I was writing this presentation, I was thinking, well, what would it be like if we hadn't just had them down the hall? How would that process have worked? And this is something that I really love about the 4 M's as an organizing framework. If you could get the organizations in a county or a region that all have some impact on older adults' lives, if you could get everyone in the region to just sort of agree, hey, this is a useful framework that we're each going to explore in our own ways, even if they don't directly coordinate their actions with each other, there's going to be synergy there. Having everyone sort of pointed towards the same priorities, I think it would bring a lot of benefit to the community, even if there wasn't strong coordination.
That's great. And I just want to observe that it sounds like in both examples, there was support from the larger organization. Is that the case? Did you have to work for that, or did you do that already with the groundwork before you went out and developed these community partnerships?
No, I think you're exactly right there. Again, everything happens if you have good support from your leadership. And was going to say this with the next question, but we even have more support. It was just recently that the Dr. Dennis Freeman, who was our CEO for 40 years, passed away. And he had, at the end of his life, had needs, and our current CEO said it took 5 medical professionals to get things organized and help them maneuver the systems that he needed at the end of his life. And that has really burned into our Dr. Cottry's brain now, that we have to be part of these strategic partnerships in order to really meet the needs of the older adult. And so I think, we're headed there. But Laura has done the initial outreaches, but we're committed now to bring more as we can in-house. We haven't had the luxury of Illinois to be able to do as much in-house. But to develop those partnerships, what do we want in-house? What do we need to partner with others, but have tighter connections and communication so that we can really help older adults navigate the systems that are such barriers to them.
That's fantastic. One of the scariest things for me is what you're describing here is when I see older adults going alone into healthcare, in primary care, especially in hospital care. And I can't tell you how many times I've interviewed providers of all stripes who said something to the general effect of, if an older person doesn't have a strong advocate or family member, there's going to be complications. The system's just not there. So to hear you speak this way, to think about working with the patient rather than just provider on patient, but to think about the patient in the environment, the whole environment that they live in, it gives me great hope, and I'm inspired by your words here. Which leads us into this next question. Where are we going with this? What are the next steps here? What do you think the future of age-friendly care looks like? Do you want to start, Dr. Peterson, on this one?
Sure. There's a lot of ways I could answer this, but two things that come to mind for me. First, mobility. We used to have a dietitian who was also a personal trainer, and I miss her. Because for a lot of patients, they may not need the technical expertise of a physical therapist. They may just need somebody who can talk to them about physical activity. You know, just do some basic problem solving. What is it that you enjoy? What do you feel comfortable doing? What fits in with your life right now? And I hope that's something that we can figure out how to bring into our care teams on a more regular basis. Second, I'm kind of intrigued to see now that we finally have a care plan module in our EHR that allows us to centralize a lot of these patient priorities and goals and these life factors that is obvious and accessible to the care team. Where is that going to take us? So as we train different groups of employees to document in there, what will people like, what won't they like, and what sort of care will it encourage as we become used to that reframing.
Thank you. Dr. Porter, Dr. Wallace, what's the future? What's next?
I think that we still have work to do in the development of our staff, and we have more clinics we need to bring on to this process, but we want to be able to have the 4 M's, the age-friendly concepts in every step of the patient's encounter at Cherokee Health System. So we still have a lot of training and still continuing to reevaluate our processes. I think the point about the EHR is so essential. There's still work to be done so that we can easily see, first of all, what's important to the patient. Again, the patient-centered care we need to continue to emphasize and develop. We do have the aspiration to be IHI level 2 recognized. We want to be a quality center for age-friendly care. And Laura, why don't you talk about, something that's very dear to you about the environment?
Certainly, yes. So I think not only to be very mindful of our physical structures, the layout and design of our buildings to be age-friendly, space, age-friendly exam beds, lighting, colors, accessibility, and also even bigger picture, climate change on health and vulnerabilities of older adults. So lots of refinement and expansion to do with our kind of big picture strategic planning around that piece, as well as clinical training and electronic health records.
Thank you. Thank you. And you can see in the chat, Juliet requests, if anybody has questions, please bring them forward. But I have lots of questions, but I'm going to keep my mouth shut.
I did want to ask the panel, because we did get a question around how providers were trained. So I think it's kind of a multi-step question. So I'd love our panelists to both talk about in general, like the geriatrics workforce enhancement program and your connection with Rush, and then kind of a little bit more about the modules that some of your providers were then able to participate in. If both health centers want to help answer that question, that would be great.
Go ahead, Erica. Well, we both have used the same tools, so I'll let you take that one.
So yeah, I believe it's catchon.org, but I will, send Ariel the exact link later. Rush University has put together a whole list of educational modules, and they're at 2 levels. So there's some that are for clinical staff that get into the medical side of things in more detail, and there's others that are for your receptionists, your billing staff, your leadership staff, anyone in the organization who wants sort of a basic understanding of what the 4Ms are, and other aspects of appropriate care for older adults. And they also have patient-facing videos that patients and families can watch to get the 4Ms at their level. So that was a great resource. And then Rush University also had some learning communities that our staff participated in.
Yeah, we're part of a monthly learning community, and we have and again, each quarter is one of the M's, and so that helps again continue to emphasize the structure that we want in taking care of the older adult. That's been very helpful. And to go back to the Dementia Friends project, the videos are short, simple vignettes. It's really for the general audience, but it's very useful information in how to recognize and support individuals with dementia or other cognitive decline. And I can tell you, after I watched those, it was literally a couple of days later, I was out walking my dog and I met a woman out on the street. And of course, it took me about 2 seconds to recognize that she had dementia. And I was able to use the tools I learned in those vignettes to help get her, redirected and get her back to her home. So there's lots of things. Your different organizations have tools, but you do need structured training, and the Rush program has certainly been just a godsend for us.
Great. And I think we'll take just the one last question I see in the chat box, which is around how each of your health centers might utilize whatever community resources that are available as a team. You list them for older adult patients to connect with outside of your facilities. Kind of how do you go about making either those referrals or letting them know, the patients know, that those resources are available?
Right now, we do have some of those resources and handouts for patients. We need to be more intentional in that. Our behavioral health colleagues and our community health coordinators are great resources to help our patients. We try to be very intentional in our integrated care. We, every opportunity, me as a primary care provider, I bring my behavioralist in and we look to find the resources. I think one area we haven't talked about, but that we want to develop some stronger relationships with, is some legal help. A lot of patients have legal issues, or, how do you maneuver these systems? We do have people within our organization that help them to navigate insurance kind of issues and enrollments there, but we want to continue to develop those relationships and then be able to help direct patients to make those connections. The other thing I'll be quick on this one, that we have in each of our exam rooms Zoom TVs. What I envision, I hope in the future, is that we would be able to, if you have a family member that can't be there, that we could connect them into the visit with the Zoom TV. Or if we have a resource that we could easily access to make those connections, I think the future is wide open for those kind of connections down the road.
Excellent. Well, I know we're just at time, so I know we could continue this conversation around, individual resources that are available in your locations and more about your implementation experience so far. But we're so appreciative of the expertise of our facilitator, Dr. Marimaldi, and from our representatives on our panel today from Cherokee Health Systems and Shawnee Health. We thank you so much for your time. We hope that those in the virtual room will take a moment to fill out the quick evaluation. We'd love to hear your feedback. We also would love to see you in our next webinar in a couple of weeks on care mapping. We did mention this in session 1. It's a great tool for family caregivers of older adults. So we hope that you'll join us again soon. And thank you so much again for your time. Have a wonderful rest of your day. Take care. Thanks, everyone.